joining us today. For those of you that are regulars, we have a special treat for you today. I'm Dr. Christopher Rogers. That's not the special treat. Dr. Umbach is joining me as well today, where we talk about cell therapies versus surgical care for knee joint pain. We're going to introduce a little bit later a friend of ours, Dr. Bill Murrell, an orthopedic surgeon who is well known. He lectures all over the world. And so we're bringing him to San Diego today. And he's going to share with us some of the special things that he's been working on.
Yeah, thanks everyone for joining us. We're excited to have Dr. Morell. He is an international guest speaker, and I think you'll learn a lot from him being an orthopedic surgeon and sharing his knowledge, experience, and insights on these non-invasive, non-surgical treatment options for knee joint pain. So Dr. Rogers and I will do a quick introduction slides to his lecture. Most of the time for this webinar was reserved for his presentation, and then we're gonna follow that with a question and answer portion. So while listening to the lecture, if you do have any questions, just go ahead and type it into that chat button at the bottom of your screen. And then after we're done with the presentation, we'll get to those questions and answer them one at a time. Dr. Morell will also answer questions on the topic after the talk.
Great. So as I mentioned, I'm Christopher Rogers. I'm a physician here in San Diego. Been in practice for 23 years. Board certified in what's called physical medicine and rehabilitation, as is Dr. Ambach. We're both physiatrists, which is a non-surgical specialty that focuses on the musculoskeletal system. So we're experts in non-surgical orthopedic care. We are both fellowship trained. I'm fellowship trained in sports and spine, and as is Dr. Ambach, which means that we resisted the urge to get a job after residency, and we decided to do one more year of training. We were both blessed to work with very talented physicians who trained us back, for me, it was back in 1997. And we've been lecturing on regenerative medicine. Did we lose our slide? We've been lecturing on the regenerative medicine now for at least the last 8 years. And that's actually how I met Dr. Umbach. Dr. Umbach's going to bring us back. Great. We're overachievers, so we like to do research. We like to publish book chapters. We like to give lectures. We like to teach workshops. So we're very involved in the regenerative medicine community, which is where we get to meet a lot of great people and train the next generation of physicians who will hopefully integrate these new therapies into their toolbox as they treat their patients. Last year, we conducted a FDA-approved clinical trial for knee osteoarthritis using stem cells from a patient's own body. And that report was just recently submitted to FDA, and we're going to be moving forward to a phase 2 randomized clinical trial probably early this summer. Dr. Ambach was also a participant in a multi-center randomized clinical trial looking at treating patients with chronic low back pain and disc degeneration using cell-based therapies. And we'll be talking a little bit about some of these cell-based therapies. Our special guest today, which we'll introduce in a little bit, Dr. William Morell, is a board-certified orthopedic surgeon. You know, we get a lot of questions, by the way, as non-surgeons doing innovative therapy. What do the orthopedic surgeons think about this new medicine, these new cell therapies, and the potential for them to replace some of the existing orthopedic surgeries that are performed, such as a meniscectomy or a joint replacement? And I always answer the same way. I say the more progressive ones, the orthopedic physicians who understand cell therapy realize that this is the future of orthopedic care, and they embrace the technology. Not only do they embrace the technology, but they're pushing it forward by conducting research. So this is how we met Dr. Morell. He's a shining star in the field. He's also fellowship trained in sports medicine, where he specializes. He's a consultant for and director of the Orthopedic Center of Excellence in UAE, and he's the president and founder of the American Academy and Board of Regenerative Medicine, which is a new organization that brings together different physicians of different specialties who have an interest in regenerative medicine. And then he founded the Dubai Sports Medicine Center, which is a real premier world-class facility that brings a lot of the technologies that frankly aren't even available in the United States yet, and brings a lot of expertise to that area. So we're going to first start with a basic introduction to cell-based therapies for joint pain. And then we'll talk about some of the surgical options as well. We'll hear from Dr. Morell, and then at the end, we'll take your questions. So our company is called San Diego Ortho Biologics Medical Group. OrthoBiologics is a term that we want everybody to learn. It simply refers to orthopedic treatments that involve the use of cells or substances, molecules that are derived from cells. And it's based on the premise that in regenerative medicine, we understand that the body has a natural ability to heal itself. And so we're just learning how that happens, and we're augmenting those processes to help injuries that are having trouble healing. And some of the common orthobiologics you may have heard about are platelets, which are cells in your blood, stem cells, I'm sure you've heard about, but you may not have heard about some of these growth factors, cytokines, or other molecules that the cells manufacture in their attempt to help heal injured tissues. This is a little shout out to our YouTube channel. If you just can't get enough of us, go to YouTube and type in San Diego Ortho Biologics, and we have probably now 20 or 30 lectures on there for you to view at your leisure. These particular lectures talk about some of the more common orthobiologic therapies that we offer. These are cell therapies derived from your own fat tissue, adipose tissue, from your own bone marrow tissue, or from your own platelets, from your own blood. So you can watch those at your leisure. Probably the most common thing that we do in our office, and you may be the most familiar with, would be something called PRP, or platelet-rich plasma. Platelets, as I mentioned, are cells in your blood. We can obtain them by drawing, through a simple blood draw in the office. And then we centrifuge. You can see behind me the centrifuges that we use. We have a sterile hood over here that we use to process and make a customized platelet-rich plasma product. We don't do a cookie cutter approach. Everybody gets their own customized version. You can see also we have a cell counter, so we can measure the dose of cells that we're giving you. These cells release growth factors that stimulate your tissues to heal. They form new blood vessels. They call stem cells into the injured tissues to help with the healing. They also decrease inflammation. In a lot of ways, they might function like cortisone would, where you decrease inflammation in an irritated joint. The difference is it's safer and it lasts longer. Next slide. As I mentioned, we customize our PRP. There's at least 37 different flavors of PRP. The most common flavor are cranberry, orange, and pineapple. I'm kidding, we don't take our PRP. But you can tell that some of the PRP may have more red blood cells in it, giving it that red color, and some have fewer red blood cells, making it more of a pineapple juice color. So for example, in the knee joint, we don't want to inject red blood cells into the joint. The iron, the hemoglobin in the red cells is not good for your cartilage. And so if you're going to have PRP injected into your knee joint, make sure it's not the red bloody kind. We would use that more for a wound or for a really stubborn tendon tear. But more commonly, we use the ones on the right. Next slide. Now, Dr. Umbach, you want to tell us something about stem cells?
Yeah, so there are more than 37 trillion cells in our body, and these cells are constantly dying and being replaced. And stem cells are responsible for replacing lost cells due to either injury, wear and tear, diseases, or other reasons wherein we lose some of these cells. Stem cells are unique in the sense that they don't just have the ability to renew themselves and help us grow, as our physical bodies grow from a kid to an adult person, but they also turn into other cell types depending on what our body needs. And they're the only cells that can do this. In orthopedics, we are particularly interested in as adult stem cell that's called mesenchymal stem cells. And this is a specific type of adult stem cell that can differentiate into other cell types that are useful in orthopedics, like muscle tissue, cartilage tissue, bone tissue, fat, blood vessels, and nerves. Dr. Arnold Kaplan, which is the gentleman here in the middle in the picture on the upper left here, is the father of MSC, and he named mesenchymal stem cells about 25 years ago. And he founded mesenchymal stem cells. He's a professor of biology, Case Western Reserve University. So these MSCs just lie or live around our small blood vessels in our body, just waiting to be activated whenever they're needed. And once they're activated, they release hundreds and hundreds of molecules. They act like mobile drug stores. Basically, they release these natural drugs and molecules from our body that serves many functions, some of which involve tissue healing, controlling inflammation, fighting infection, and helping with pain. The stem cells that we use in clinic are derived from either the bone marrow or adipose tissue, which is not processed by enzymes. These tissues are what we use in the clinic. They are compliant with current FDA regulations regarding the use of cells in the office. Cell-based therapies as a whole have a lot of studies to support its use. I know it's a completely separate lecture just to go over data and evidence on its use, but it's got hundreds of research proving that it's safe to use, that it helps decrease inflammation and pain, increase in function. They will also have clinical research to show how it works, and we have discussed some of the mechanisms by how it works. And this is to stimulate tissue repair, increase blood flow, help with the pain, and fight infection. So we're going to start with Dr. Murrell's lecture, and we're going to finish that lecture and then finish it with the question and answer portion.
Today, we're going to talk about cellular therapy versus surgery for knee joint pain. Here are my affiliations and disclosures. I currently work at Health Point Hospital, Abu Dhabi Knee and Sports Medicine Center. Pretty big facility. We have 15 orthopedic surgeons divided between upper and lower extremity. About 50 physical therapists. We have over 1,200 outpatient visits a day, over 200 surgeries done per month. Today's main points of this talk will focus on 4 areas. One, really the main issue to addressing most knee joint pain is lifestyle related issues. This will be talked about the first part of my talk. The other point is that most of the problems that we see for the knee joint can be managed with non-interventional, non-operative treatment most of the time. Minimally invasive interventional therapeutic options like orthobiologics and other cellular-based therapies can work for most individuals most of the time. Other times, invasive interventional procedures like surgery can also use orthobiologics in many instances, but for the most part, at least in my hands, most procedures are done non-surgically. And I'm an orthopedic surgeon. I've been in practice for about 20 years. I'm going to make a prediction prior to the start of this talk, and that is by 2040, I think that we will become much more effective at treating the primary problem, which is lifestyle for many locations in the world, maybe not San Diego, but certainly around the world, we're dealing with issues related to lifestyle most of the time. And what I've seen in my own practice since 2008, where I would do 400 to 600 cases a year, I found that most of my cases in up to 2018 have become interventional. About 72% of the cases that I do are now interventional. And as an orthopedic surgeon, we do involve ourselves in the managing lifestyle-related issues because we're doctors too, and it's just not about doing surgery. Managing lifestyle is about choices, and we can choose to eat well and rest and take adequate water and eat right foods, non-processed foods. This is really our choice. We can do the things that feel good, and these things have consequences. And these consequences one of the consequences is obesity. I know this may not be a big issue in San Diego, but in many places in the US, as well as the UK, here in the Middle East, we have major problems with obesity. And what are the major issues with this? Well, when you're obese, you have marked effects on your genetics and your genetic stability. And so when your genes are unstable, all the proteins that govern all the biological processes in your body, the metabolism and such, become unstable. So the proteins that your body makes don't work. And when they don't work, things like generating energy, even though you have an excess of energy stored in the body, your mitochondria are poisoned and they can't even make energy to do the normal processes of the body. And this is why a lot of people that are obese are quite tired. And being obese has had a huge impact on the prevalence of osteoarthritis. It's expensive to manage, over $2,000 per individual per year, 80 billion in lost wages, 25 million individuals unable to do normal activities because they're arthritic. And not only that, because all of these individuals are inactive, it makes it harder to manage conditions like diabetes, heart disease. Right now, we have about 30 million individuals with osteoarthritis in the United States. It's projected to be almost 80 million in the next 2 decades. Managing NEOA, we do the best that we can, weight loss, exercise, physical therapy, oral medications such as anti-inflammatories, analgesics. But at the end, when none of these other things work, we can also use OrthoBiologics too. I didn't mention that. But when none of these other things work, we tend to turn to surgical treatment. And we know that surgical treatment is not as straightforward as we would like. You get blood clots, infections, have nerve damage. And it's not only that, it's expensive. We know currently in the United States, it costs about $26,000 to perform a knee replacement. And we know that it needs to be about $14,000 to be cost effective. So right now, if we did surgery, we can only do surgery on the most severe cases for it to be cost effective. We also know that if we do an early knee replacement, the costs to society are much greater than if we do the procedure later, about $8,000 if early knee replacement versus late knee replacement. Well, one of the solutions that we are putting forward, especially doctors like Dr. Chris Rogers and Dr. Annette Ambach, is using OrthoBiologics to treat some of these patients that are young, that may have moderate disease or moderate to severe disease, but is not quite old enough for doing a replacement. However, the position of the American Academy of Orthopedic Surgeons and other organizations is that we basically don't have any evidence to support us using OrthoBiologics, but this is the furthest thing from the truth. This month we published this nice little editorial, and it basically outlines all the compelling evidence that OrthoBiologics are not only safe, but effective for treating knee osteoarthritis. This is a slide made by Jerry Malanga, who was former president of the Interventional OrthoBiologics Foundation. This was done in early 2020, and at that particular time, there was about 5,600 patients that had been studied in trials since 2011. I know this number is over 6,000 patients now in early 2021. So we have lots of evidence to support not only the use of micronized fat, stromal vascular fraction, also adipose-derived stem cells to treating knee OA. OrthoBiologics can also be used to augment orthopedic surgery. This is one of the treatments that we use it for is for ACL repair using bone marrow aspirate concentrate. You can see the full thickness tear of ACL in this MRI image. And this is the report prior to treatment. You see complete tear of the ACL at the femoral attachment. We take the bone marrow posteriorly. This can easily be done in the clinic or in a treatment or in a procedure room with or without sedation, but with local anesthesia. It's very comfortable. It's not a difficult procedure. You can see this is the MRI after 1 year. You can see that the report, the ACL is intact. And again, this is what it looked like after 1 year. So this is before with the tear, and this is after. And so we also do functional testing, and for the treated knee actually ended up being better than the non-ACL knee. We know that we like to do ACL reconstruction in these patients that have recurrent instability. We have improved the amount of osteoarthritis after ACL with this surgery. However, it's not perfect. We know that up to 45% of patients will develop knee OA in the knee after reconstruction within 10 years. And so this is why we need to come up with other strategies to help address this problem. And one of these things is to do ACL repair, because we preserve all the nervous structure that are important in signaling the hamstring muscles to fire, to protect the ACL. And also you don't see the cognitive changes that occur after ACL reconstruction or ACL tear when you're able to preserve all the neurologic structures that are contained within the ligament itself. This is a study looking at PRP and ACL tears. These were Division I football players in Spain. 18 of 19 were able to get back to their previous level of play within 4.5 months. This is a study by Centeno, 10 patients also using bone marrow aspirate concentrate. And again, 87% of these patients had marked improvement. And this is the pre-treatment MRI and post-treatment MRI. You can see markedly improved. So what is the best regenerative medicine treatment? Well, we've used all of them, and I don't think that there is a best treatment. I think that there is an effective period of treatment. I did not include micronized fat. I need to update this slide. But I think basically, all of them work well. And I think the difference is that some of the treatments require more frequent treatments. For example, HA, this is something that's covered by insurance. It works. However, if you use it, you're going to need to administer, once or twice a year, and then have to repeat. PRP, I think, lasts a little bit longer, about a year. It's quite cost effective as compared to HA, at least in our practice. Conditioned serum, I think, is very promising. The cost is about $3,300 for one treatment. And we have some patients even up to 8 years for knee OA. BMAC, again, I think is an effective treatment. It costs in our practice a little bit more. Culture expanded cells, I think, again, effective treatment, but the cost is a bit more expensive. However, I think this cost will decrease with time. And thank you.
Thank you.
That's a great talk, Dr. Murrell. He can lecture to us for hours with all his experiences and all the different biologics that he's integrating in our practice. So we want to focus on just the joint pain for today's lecture. but we can go ahead with the question and answer portion. Dr. Rogers, there's a question here regarding can we use stem cells for cartilages that do not have blood flow?
Oh, I see. So, well, first of all, as you probably know, cartilage does not have blood flow, with the exception of maybe the periphery of your meniscus in your knee. You know, these tissues, cartilage, tendon, ligament, they are designed to not have a robust blood flow, probably because these tissues are under compression and stretch, and that probably would be problematic for blood vessels. I'm assuming, I don't know the real reason. The cartilage in your knee gets its nutrition from the fluids in the joint. So the lining of your joint has a tissue called synovial tissue, which is vascular. And a lot of times that tissue, when people have osteoarthritis, that tissue is inflamed. That vascular tissue will secrete molecules and proteins, et cetera, into the fluid of the joint, the synovial fluid, which that synovial tissue is manufacturing. And then through just repetitive compression, you know, when you go for a walk, you're intermittently compressing the cartilage in the joint. Those tissues will absorb the synovial fluid, and that's how the cells get their nourishment. So there's a mechanical component as well as a biochemical component. So the question is, can we use stem cells for cartilage? There are a number of studies that show that stem cells differentiate into cartilage cells. So we know that. So you can take a stem cell, put it in a petri dish, and if you feed it the right fertilizer, it will transform or differentiate into a cartilage cell. But we think that when we treat you with stem cells, so if we collect stem cells from your bone marrow or from your fat tissue, which has these stem cells that Dr. Umbach was showing you that picture, those stem cells will secrete those molecules that she talked about. And those molecules will turn on genes in your existing cartilage tissue, in your existing cartilage cells, and get those cells to function. So they'll proliferate, meaning they'll make more copies of themselves. They will manufacture collagen, which is a protein, better. They will downregulate or inhibit the release of certain molecules that are harmful to cartilage. So there's a combination of tissue regeneration and healing, as well as an inhibition of things that are harmful or degrade cartilage tissue. So it's an overall healing effect on the tissue. So very long story short, yes, stem cells have been shown again and again to be helpful for cartilage injuries.
So in the same manner, there's a question here with regards to meniscus tear. With the same mechanisms as Dr. Rogers has mentioned, these cells help in the same way with healing as what he described. PRP works a little bit differently with stem cells. They act like a general contractor. That's how I would describe them. When you have platelets in the area, they are basically start working by calling on all the different cells that are needed to go into the region and start the repair. So that's either to decrease inflammation, to stimulate formation of tissue, help with the pain, increase blood flow to the region. And that's basically the mechanism by how they help, whether that's a torn tendon, a torn meniscus, a torn ligament, etc. So next question, Dr. Rogers, do you use extracted exosomes in treatment?
Do I do what?
Do you use extracted exosomes in our treatments?
Oh, I see. Oh, well, I guess I have to define what an exosome is. An exosome, well, in the words of our friend, Dr. Kaplan, who you saw a picture of, he's a professor at Case Western. He's the man who discovered stem cells, mesenchymal stem cells. If I could borrow his exact quote while we were sitting eating pizza together, he said that exosomes are stem cell poop. And so basically what he meant by that is stem cells are secreting these molecules. You know, we mentioned that already, but there's different ways that they do that. One way they do that is they wrap it up in a little package and then they excrete, they poop out this package And if the package drifts in the fluids and finds another cell, that cell will ingest it. And those molecules that were in that packet could then work their way to the DNA of that cell and then turn on certain genes. And we think this is one of the common mechanisms by which stem cells function in the body, by passing these messages. So we say stem cells don't have cell phones, so they use exosomes to communicate. And so you can think of that exosome like a text. We think the cells are smarter than just using text. So you can manufacture a drug. You could take a bunch of stem cells in the lab, let them make these exosomes, these little packets of information, DNA and RNA and proteins, et cetera. And then you could process them in a way where you could bottle them. And so there are a number of companies and clinics that sell these products currently. There's only one problem, and that is that it's illegal. Not illegal in the sense that you will go to jail, but illegal in the sense that the FDA says, don't do this. It would be equivalent to Dr. Rogers inventing some new antibiotic and then suddenly treating all his patients with this new antibiotic. You can't do that. The FDA says, you better do a safety study, at least one safety study, test it first, to make sure it's effective, test the efficacy of that new drug. And then if you're lucky, the FDA, after 10 years of doing all this research, will give you the approval, a license to manufacture or to market that drug and sell it. And so what's happening is a lot of these companies are trying to bypass the FDA. So our general recommendation is don't get exosomes injected into your body, even though we think there's some basic science there that's sound. There's some good evidence there. There's really no evidence that these are safe. Particularly if they come from somebody else's body, you're getting their DNA, their RNA. And so we need to have safety studies first. We need efficacy studies next. We don't have that. So if your doctor says, hey, I have exosomes, I'm going to inject it, you can say, well, it's illegal and you have no evidence that it's safe or effective, so I don't want it. So that's my comment on exosomes.
Yeah, that's right. I mean, these molecules have a lot of potential. The initial data seems to be, as Dr. Rogers said, seems to be promising, but we just don't have enough data right now to support its use and efficacy in clinic. So we have Dr. Murrell answering some of the questions as well that were submitted. So I'm gonna let him answer some of the questions and then we can go back to the other questions that we have here on the deck.
Okay.
So I think if we look at the chat, I think we have some questions coming in. Let me look at the questions. Hold on one second. One of the questions is, which OrthoBiologics do I use in our practice? Well, we pretty much use all of them. However, lately we've been using a lot more of the gold-induced cytokines just because it's easy and it's pretty, and it seems to last longer than all the other treatments, including the culture expanded cells. We do have some patients that have gotten culture expanded cells that have done extremely well, but on average, it seems like the gold-induced cytokines works the longest, and for the price, it seems to be maybe the most cost-effective, but we have not studied that conclusively yet. But this is kind of our intuition about it. Second question is, which patients do well with biologics versus surgery in my experience? Well, I think for sure, well, we need to separate. Well, first of all, my approach to doing surgery is operating on individuals that fail all conservative therapies. And that includes orthobiologics too. In general, I like to use therapies that are covered by insurance. And in the instance that a patient is no longer doing well, we can go to other therapies like orthobiologics. Some conditions like ACL tear, if they're an appropriate candidate, I like to offer doing the ACL repair because I think it works well. However, despite having good evidence, we've treated about 19 patients so far, and none of those patients have gone on to ACL reconstruction. Most patients still want to do ACL reconstruction. Well, number one, is covered by insurance, and number two, we don't have a lot of evidence to support us doing it. So, but I think OrthoBiologics are quite viable. And another question is, how do I decide when to proceed with surgery versus OrthoBiologics for OA? Well, for OA, I think most patients can be managed non-operatively. Physical therapy, weight loss, strengthening, readily available injectates, which may include HA, prolotherapy. We did a nice systematic review on prolotherapy. It's also quite effective. PRP, micronized fat, really all of these things can work. However, it's really more about how long they work. And I think some of the things like micronized fat, they last longer than PRP. I think culture expanded adipose derived cells last longer. I think the golden induced cytokines also last longer. So these are the things that we keep in mind. But I think for OA, and when none of these other therapies work, then I think total knee replacement is appropriate. But of course, we want to try to delay that as long as possible. Meniscus tear, it really depends on the type of tear. If it's a degenerative type tear, so these are horizontal tears, I tend to manage these with physical therapy and injections. And really all the injections we previously spoke about, I think work, and we've published on that as well. But if it's a traumatic tear, that's a vertical component in a younger patient, I think that this is a patient that we will operate on more quickly. And of course, if it's an isolated tear, because the risk of failure with isolated repair is higher, I always use OrthoBiologic. And these days we've been making a bone marrow aspirate matrix. It's very easy to handle. Or we can make a fibrin clot, which is a little bit more difficult to handle. We inject into the repair as well as on the periphery, and we seem to get really good results. Ligament tear, I think we talked about it. I will offer an ACL repair to patients. Like this year, we've only done 2, but like, as I mentioned, most patients prefer to go forward with surgery. But I do think that the ligament repair with OrthoBiologics, I think this works. And it says, do I use cellular therapy in conjunction with surgery? I think the area that I use it most is for meniscus work, as well as for rotator cuff repair. There's very good studies that show that bone marrow aspirate concentrate works to help heal rotator cuff repair. And I had some shoulder case I was going to share with you, but I didn't. I had enough slides, so I didn't want to overload you. I probably overloaded you already, but I didn't want to give you too much more. But yes, I use it mostly with shoulder and meniscus, but also we use it for cartilage work in the knee. And so we find that it's a very helpful adjunctive care to make sure that we get a better healing response in the knee. It said, another question, in the US culture stem cells are not permitted by FDA, but they are in Dubai. Can you talk about that? Well, in reality, we are using the culture expanded cells off-label. They're approved for aesthetics as well as for breast augmentation if the plastic surgeons are using adipose tissue. But we've been using them since 2015 in the off-label way for degenerative joints. And so far, we've had no big complications or problems or adverse events, quite safe. And here in UAE, we don't have quite the same due process for malpractice. And here, when you make a mistake or a person has a bad outcome, it's considered criminal and you can do jail time. And so most people are quite hesitant to do things if they're not totally supported. But I've been so impressed with the lab here and their transparency in producing these current good manufactured processed cells that are totally characterized, that we have not had any problems whatsoever, and the government has been very supportive of that. And they have not come to us about using them off-label. So, so far so good. But I do think with studies, I think that not only SVF and culture expanded cells will be available. I think in the US, I think very shortly these things will be available because we're all doing the studies. And final question I got is, what would I predict to be the future of orthobiologics, orthopedic surgery? Number one, I think that, as I mentioned before, we will use it to augment some of the surgeries that we're doing, specifically for cartilage work. Number two, I think for augmenting repairs of tendon, especially ones that are difficult to heal, like the rotator cuff. And we have great data to support that. I also think that we will use it as a bridge prior to joint replacement more and more. So I think the days of doing joint replacements in 35-year-olds up to, say, age 55, I think will, over time, largely be supplanted. And this would be a primary treatment. And I think treating osteoarthritis of basically every joint will become an area that we will use orthobiologics. For the spine, this is an area that our gold-induced cytokines work very good. It's a epidural injection, so we don't have to inject the disc. Injecting the discs with orthobiologics, there have been studies that have shown safety and efficacy. However, I think we don't have clear guidance on that yet, but it would be interesting to see what Dr. Chris and Dr. Nett think about that. But I think orthobiologics are here to stay, and I think we'll see more and more people using them. And I hope that more of my colleagues in orthopedic surgery will use these treatments. And that's it. Well, thank you very much for all of your attention and time. I think I've gone over a little bit on my time, but again, thank you very much. And I appreciate you being attentive and being open to listen to us about this very exciting area that is transforming the way that we treat patients right now and today. And so again, thank you for all of your attention.
Thank you. So I really great overview. As you can tell, this is a very rich topic. There are many areas that we can discuss. We just want to give you folks an idea of what's emerging in the field of orthopedics and where we are at. You know, for all of us, I think we can't get there quickly enough. We want to have the safety data. We want to have the efficacy data. We want to know where these biologics are effective, what conditions respond best. That work is being done by our colleagues all over the world. That's why we wanted to bring to you some of these great minds to our little talk here in San Diego. I can see on the call today, we have actually some other great minds. Maybe we'll have you on a future call. But we're getting a lot of questions about PRP. So if I could just do a quick summary, Dr. Umbach, about platelet-rich plasma. This is probably the orthobiologic that's been the best studied at this point, and yet there's still much more that needs to be done. So we're talking about collecting your blood and isolating components of your blood, predominantly platelets and plasma. And there have been a number of very good studies now looking at their effect and safety in knee osteoarthritis. This is probably where we have the most data in the whole field of orthobiologics. We have a number of prospective randomized clinical trials comparing efficacy and safety and durability of the treatment for knee osteoarthritis, comparing to standard of care. So comparing to hyaluronic acid, which is a gel that we can inject into your knee, or comparing to steroids, which has been used since the 1940s. And basically these studies all come out saying the same thing, that PRP is effective and safe for mild to moderate osteoarthritis. One of the attendees asked, how about for severe osteoarthritis? Generally, the success rate is not as good for severe osteoarthritis. It's probably around 50% of our patients will get 6 to 9 months relief from a single PRP injection when they have severe knee osteoarthritis. But for well-selected patients, we can do better than that. But in the published literature, generally the more advanced osteoarthritis doesn't respond as well to PRP. So we might consider some of these other orthobiologics that we were just talking about. But PRP has been shown to be safe. Unfortunately, it's not yet covered by most insurance, even though we have, I would say, pretty good evidence. One of the challenges right now with the evidence is there really is very poor standardization of the treatment itself. Like I said, there's at least 37 different ways to make your PRP product. If I inject cortisone in your knee, that's an FDA-approved drug that's very well characterized. We know the dose, we know the potency, we know pretty much everything about that molecule. When we inject the PRP, it's very different depending on even the time of day in which we draw your blood, the food you might have eaten that day, whether or not you exercised that morning. All these things need to be standardized, and so there's work being done on this, and we'll get there.
That's a great summary, Dr. Rogers. For PRP treatments, there's a question here with regards to when do we know how to decide when to use fat cells versus bone marrow cells, and what are the pros and cons for each treatment. As we showed in our slides, the adult stem cells that we use in the clinic are obtained from either the bone marrow or the fat cells. There's really no concrete evidence yet with regards to which one is better than the other. There was a publication with the use of comparing bone marrow versus adipose cells for the use of knee osteoarthritis, and their results showed that there was comparable results with the use of both. In our clinical practice, when a patient tends to be in the older age range, more than 65 or older, we tend to favor the fat-derived cells, because the fat-derived cells has significantly has a lot more of stem cells in number per volume of tissue compared to the bone marrow. And as we all know, as we get older, we've got less stem cells in the area. It would be interesting to know and to see how that would evolve over time with regards to research. Dr. Rogers has published their data on using fat-derived cells and tissue for knee osteoarthritis with really, really great results. So Dr. Rogers, you want to talk about that?
Yeah, just real briefly on adipose tissue is a very rich source of these cells. We have to be careful in the clinic in our daily practice that we don't call these stem cell therapies, because to call it a stem cell therapy, that means that I've actually characterized the cells that I'm injecting into my patient. So we do something called flow cytometry, where we run your cells through a processor. We look at the proteins on the surface of the cell, and then we identify that cell as a stem cell. In the office, it's a same-day procedure. So we're doing the bone marrow aspirate, just like Dr. Morell was talking about. We aspirate the bone marrow, we centrifuge it, we concentrate it. We know from published clinical studies that there's a high probability that there are stem cells in your biologic. Well, we are not measuring that in the office. That product, that processed bone marrow tissue or processed fat tissue is being injected at the same time. So that's, again, one of the challenges currently is what you get in Dr. Smith's office and what you get in Dr. Jones' office may be very different. That can be changed by actually sending your sample, your bone marrow or your fat sample, to a lab, a facility where under FDA authority, we can characterize the biologic. You heard Dr. Morell talk about actually growing the cells in culture, what they call culture expansion. So now instead of having 1 million or 2 million of these cells, you can have 10 or 20 or 100 million of these cells. This allows us to standardize the dose. And currently in the United States, you cannot get cultured stem cells in the UAE. You heard Dr. Morell say you can, but it's not yet available. Although we are studying that, we are actually submitting for a phase 2 clinical trial to study the effectiveness of these well-characterized biologics. But in the office, what most doctors that are involved in this space right now will offer their patients is a same-day processed tissue, whether it's bone marrow or adipose. The decision is, as you heard Dr. Umbach say, has not been determined yet, which is better. Our experience is that bone marrow works very well for quickly decreasing inflammation in a joint. It's also shown to be very helpful for augmenting certain surgical procedures. There's some good evidence that if you have a rotator cuff tear, that adding bone marrow will help you heal more quickly and make you less likely to have problems down the road. But this is an area that still needs a lot of work. The adipose cell therapy, same thing. We have many different ways to process the fat tissue. We're collecting data on all these different methods in an effort to sort of expedite our understanding. We collect what's called real-world evidence. So, in addition to doing randomized clinical trials, which are very helpful and very informative, unfortunately, it takes a long time from concept to actual publication of your paper, and by then, you already have 20 more research questions to ask and study. So by collecting real-world data, like Dr. Morell's doing, where he's collecting the evidence on how well his augmented surgeries are doing or how well his cultured cells are doing, that's going to hopefully expedite our understanding as well as inform future clinical trials. So again, just realize we're still very early in this field of orthobiologics. We're very encouraged by the early results we're seeing, but there's still quite a lot of work to be done.
One thing that I would like to add with the use of bone marrow for knee osteoarthritis, whenever the arthritis becomes severe and the cartilage gets worn out, it starts to affect the bone underneath the cartilage. And we start to see lesions in the MRI, which we call bone marrow lesions or subchondral defects. And when the bone starts to get involved, there's some evidence to show that injecting bone marrow cells into the bone itself, so we call that intraosseous injection, actually helps significantly with pain and function and earlier recovery. So that's one condition wherein we tend to favor the use of bone marrow tissue to inject for your joint and also intraosseously into the bone. Next question, there's a question here regarding if this works for CRPS. CRPS stands for complex regional pain syndrome. It's not really related to our topic right now. However, there's no data yet on the use of these cells for CRPS. It's a condition wherein there's a central sensitization, wherein the nerves in your central nervous system gets very sensitive to pain, such that you have this increased sensitivity to a sensation that's supposed to not elicit any pain. There's some data with the use of PRP on nerve irritation for, let's say, carpal tunnel syndrome, which is the nerve irritation in your wrist, or even for sciatica or nerve irritation in your back. But we don't know of any data for the use of complex regional pain syndrome.
Great, yeah, and going back to that question on bone marrow versus adipose tissue is such a rich topic that we could probably lecture on for hours. We can go over some of the studies that have been done. Dr. Morell mentioned that this year, a few months ago, actually, we published a retrospective analysis with 2-year follow-up on patients with knee osteoarthritis. These were patients who were on average in their early 70s. Most of them had very severe knee osteoarthritis, and we're looking at joint replacement as their only remaining option. Most of these patients had already had conservative care. Some of them had had PRP. Many of them had had hyaluronic acid gel injection, cortisone injection. and had been dealing with knee pain for many years. This was a multi-center international study where 5 different sites pooled our data together and did a statistical analysis. And basically, we were able to show that 88% of our patients were satisfied with their outcomes at 2-year follow-up, which is probably, to my knowledge, the longest duration of relief for any single joint injection. There are a couple of studies that looked at cultured stem cells, but as I mentioned, this is not yet readily available in the United States. So in terms of the things that are available currently, we have some evidence for this minimally processed adipose tissue, what we call MFAT, or microfragmented adipose tissue, where basically we do a mini liposuction, rinse and wash the adipose tissue, and then inject that into the joint. And there's good evidence from our study and others that it's safe and effective, given that your patient selection is good, meaning that patients don't have severe malalignment of their joint or severe bone lesions. So in well-selected patients, we get a very good outcome. I should add that 91% of those patients at 2-year follow-up were able to avoid knee replacement. And this is another area where we need good studies, where we have long-term follow-up and see what the survival from surgery is. If we can show that, you know, an injection every 2 or every 4 years helps someone gain another 10 years till they need surgery, that might be really helpful for those young patients with severe knee arthritis who at 45 and 50, you know, really aren't good knee replacement candidates.
Next question, how long does it take before the injected PRP fluid dissipates from the injection site?
How long does it take for the PRP to dissipate?
Correct.
I'm not sure if we have any good data on that. I know with some of the stem cell studies that have done some pretty clever ways of tracking the cell in animals, the cells probably only stay in the joint for 3 to 6 months. But they start a process where they release their growth factors and cytokines and exosomes, and then they reprogram your immune system, they reprogram your cartilage cells, they reprogram your bone cells, and then those cells finish the job, even though the stem cells are no longer present in the joint. So, you know, we're super complicated creatures. Our bodies are, you know, 37 trillion cells that are continuously turning themselves over. And so, you know, just in that last 3 seconds that I was talking, you just killed about 10 million platelets and you grew another 10 million. So these cells are continually turning over anyway. So, but in terms of PRP, I don't know that we have good data. Maybe you know, Dr. Umbach.
No, I agree with you. There's really no data out there that tells us, you know, exactly the time frame. But what we do know is that the PRP is contained in the region. They start working on the cells in the region. There's really no data that says that these platelets eventually go systemic with regards to concerns for patients with cancer or any other related comorbidities. These are local injections that stay in the joint. But other than that, this is a topic that we would like to explore more. We always work closely with the oncologist. If a patient has an active cancer, we don't do these treatments. If patients have cancers that are treated or in remission, oncologists are 100% on board, do not have an issue with us doing the treatments. There has been no data to say that PRP or the other bone marrow derived adipose cell therapy increases the risk of cancer, and actually that has been published by our colleagues both in the US and abroad.
Yeah, and in addition, any patient who has a bloodborne cancer like a lymphoma or leukemia, we would not do PRP or any cell-based therapy. Not because we think they're unsafe, it's just we don't have enough evidence to prove that they are safe. I'm sure there are many patients who were undiagnosed who accidentally got PRP or got, at least not in our clinic, but I'm sure around the world, but I've not seen any of those cases come to light. So I don't know what the reality is there, but like Dr. Umbach said, we do have good long-term follow-up safety data on bone marrow concentrate, on PRP, on certain types of adipose-derived cell therapy. Some of this data goes out to Dr. Hernigau, who's been studying this for almost 3 decades, with some really well-done studies showing that the incidence of cancer is not increased with these therapies. So we feel that orthobiologics are probably some of the safest treatments that we have to offer. Of course, they have to be delivered appropriately, meaning that we do these procedures under ultrasound guidance or under X-ray guidance so that we can see where we're delivering the cells, so that we're not causing any tissue damage. Knock wood, I've been injecting folks for more than 2 decades, not had any serious adverse events, certainly have not had any complications, never had a knee infection or a joint infection, or any adverse event like that. So I feel that these are safe procedures. It's just really now understanding the efficacy side of things, where they work, where they don't work, and right now it's as much science as it is art. Our orthopedic colleagues, thank God for Dr. Morell and other orthopedic surgeons who are willing to explore orthobiologics in their practice. And it's going to be very difficult to do prospective randomized clinical trials, in surgical cases. As it is, we don't have prospective randomized clinical trials, placebo-controlled for knee replacement or shoulder replacement or some of these others. So we really rely on our colleagues to accurately document their experience and be objective and share this information.
So I hope we gave you a good overview on what these cell therapies are, what are their indications for non-surgical use. We gave you Dr. Murrell to give you his knowledge and experience on really teasing out, which of these patients respond well to surgical treatments and which patients he feels actually who responds well to conservative treatment or a combination of both. And really the success of this field moving forward is all different specialties working together to find out what would give the patients the best outcome. With that, I think we ran out of time, Dr. Rogers. There's a lot of questions that has been given today. There's a lot of interest, which are, it's great. And I think we've covered all the questions. If you feel you have a question that you need an answer on, feel free to reach out to us. You've got our website. We've got our email that you can reach out to us for any questions. If you want us to answer specific questions about your condition, you can email us or you could call us in the clinic so we can see you on a one-on-one consultation and evaluation. Thank you for sticking with us for the whole hour and listening to our lecture. I hope you enjoyed this session with our speaker, Dr. Murrell.
Thank you, everybody. Have a great day.